let's look at the effect of alpha-1 agonist on heart rate and blood pressure. We are now ripe to use the tracings. And as we look at the tracings, actually, let me do it for you on a separate screen so that like this, you see it happen. First, I'm going to see a baseline, and this is my baseline. My pen has been attached to a cardiovascular system, if you want, and through that baseline, I'm looking at mean arterial pressure as basically a line that is bisecting systolic blood pressure and diastolic blood pressure. Let's not forget that at the same time, between two systolic or two diastolic, I have one beat, therefore I can have information on the heart rate. If we put an alpha-1 agonist at this point, remember that alpha-1 receptors are found on the vasculature and will vasoconstrict. As they vasoconstrict, they should raise blood pressure. So this line should go up, and as it goes up, you should see the entire tracing going up with it. So let me do it for you. Here you see the tracing going up with the mean blood pressure. Notice, as I'm doing this, I am not changing systolic and diastolic pressure differences. That is because pulse pressure will not change since I had both contraction of arterioles and contractions of veins. How about the heart rate? Were they alpha-1 receptors in the heart? I see you shake your head no. And indeed, there are no alpha-1 receptors in heart tissue. So does it mean there should be no changes in heart rate? Well, not necessarily so. Remember that when you increase the blood pressure, you could actually, if you do it fast enough and big enough, trigger a baroreceptor reflex. And if there was a baroreceptor reflex, it would have to be a reflex bradycardia. Look, I'm going to do it in bright orange. If I want a reflex bradycardia, it would have to mean that as my blood pressure is increasing, I'm going to see a broadening of this tracing, showing me that now there is more time that is spent in between beats. Who causes the reflex bradycardia? The reflex drop in heart rate is due to, you are correct, parasympathetic autonomic nervous system. This is acetylcholine first stimulating nicotinic neuronal receptors of parasympathetic ganglia, and then acetylcholine again, but stimulating the muscarinic M2 receptors in the heart. Hey, so what could I use to actually block that reflex bradycardia and yet maintain the change in blood pressure from the alpha-1 agonist? I'm hoping as you look at our diagram here that you see that if I block nicotinic neuronal receptors or if I block muscarinic receptors, then I won't see the reflex. Yet I will still be able to see the alpha-1 agonist effect, and all I would see would be the brown tracings. So as you've seen it in action, I think it'll be easier now to look at our diagram in the notes. And as you look at this diagram in the notes, all we need to remind ourselves, looking at the text, is that if I put an alpha-1 agonist at the tip of the arrow, and you see an example, the drug phenylephrine. Notice ephrin, like norepinephrine. Phenylephrine as an alpha-1 agonist will increase total peripheral resistance and increase blood pressure. It will not change pulse pressure because there is both veno and arterial constriction. What you see literally is an increase in the height of the tracing. Could there be a reflex bradycardia? Of course there could be. Highlight the word potential in your notes. Potential means what it means. Do not always expect to see that broadening of the tracing showing you a reflex bradycardia. The boards may put it on, they know how to analyze it. It's not the drug doing it, it's parasympathetic that's doing it. On the other hand, if they don't want a reflex, then they won't show it. So don't always expect reflexes to be there. Just like in real life, they may or may not happen. Just have the tools ready to recognize them. And the tools ready to recognize them, let's not forget, are ganglionic blockers or muscarinic antagonists for reflex bradycardias. By the way, I suddenly forgot the ganglionic blockers. Do you remember them? Hexamethonium and mecamylamine. Muscarinic antagonists, of course, are drugs of the atropine family. Well, phenylephrine is certainly not the only alpha-1 agonist. It is a drug that would increase mean blood pressure via vasoconstriction, so you might think, oh, I know, I'm going to use it in hypotensive patients. Not so fast. The problem with vasoconstriction is the risk of ischemia that is increased. Also, problem with vasoconstriction is the potential reflex bradycardia, which is an arrhythmia. So instead of using it systemically for blood pressure issue, we actually use it often topically as part of cold medications. And the idea is to spray it in your nose as a nasal decongestant. Yeah, if it vasoconstricts, it's going to decrease, of course, the actual feeling of congestion that your mucosa has when you have an inflammatory response. Recall that inflammation always causes massive dilation, and nasal decongestants often have preparations that may contain phenylephrine. It's also used topically as eye drops in order to get mydriasis, let's not forget, without cycloplegia. As a matter of fact, it would be relevant to remember that drugs that are used then in cold medication, if they were used systemically, we'd have to worry about cardiovascular patients. If you have a cardiovascular condition, vasoconstricting in your body will never be a good idea, particularly if it's associated with ischemic heart disease. The older drug that we've put here is methoxamine. Methoxamine is on your exam because of a very old use. As a matter of fact, I'm ready to bet you that in the 21st century, none of you will ever use that drug in real life in the hospital. But if it's on your step one, know it. Methoxamine was used for paroxysmal atrial tachycardia because of a vagal reflex. What are we talking about here? Well, first we're talking about an arrhythmia of the heart where atrias are going too fast. And as they're going too fast, if we call it paroxysmal, it means this is the worst atrial tachycardia you've ever seen. You're about to panic. As you see the atrial tachycardia, what is its big issue? As you have a fast atrial beat, what if it conducted those fast atrial beat to your ventricles? Hey, fast ventricular rate, you would compromise that cardiac output. You don't want to compromise the cardiac output, do you? So, you know, what we need to do in atrial tachycardias is at the very least slow AV nodal conduction. By slowing AV nodal conduction, we'll protect the ventricles. If on top of it we slow SA nodal conduction, then we'll also decrease the heart rate altogether. Remind me a physical way of actually slowing someone's heart rate. You remember carotid massage? You press on your carotid, your heart, oops, and on top of it, I can't breathe if I'm doing that, so I've got to be careful. You press on your carotids, and the next thing you know, you're going to stop the heart. Well, instead of using your fingers to do a carotid massage, you're using a drug. And what you're using of methoxamine is its increased blood pressure causing a reflex bradycardia. And the reflex bradycardia is what slows down the heart of the patient with paroxysmal atrial tachycardia. Pretty neat. I think what the boards are attempting here is literally to make you remember that if you increase blood pressure, you can potentially elicit reflex bradycardias. Well, that's it for alpha-1 agonist. So normally following an alpha-1 agonist, we want to play with an alpha-2 agonist. Alpha-2 agonists, as said here, stimulate presynaptic receptors, particularly in the CNS centers, and decrease the entire outflow of information from your sympathetic. They're primarily used in mild to moderate hypertension, and all I want you to know right now is two drugs, clonidine and methyl-dopa, and as it says in your notes, see the cardiovascular section for more. So what do I want you to note at the same time? Do you see any diagrams with alpha-2 agonist? Any zigzag line anywhere? You don't, do you? And that gives you a little clue here. Alpha-2 drugs, they cannot work acutely. It's not as you give an alpha-2, that's it, you see the effect. Because they have to first work indirectly on synthesis and release of new norepinephrine. As such, it is beyond unlikely that your exam would use alpha-2 agonists, administer them at the tip of an arrow on a diagram, and ask you to match the drugs there. Really, when you use those zigzag lines, they'll be perfect for drugs that have a direct effect, that work immediately on the heart, and that'll be primarily alpha 1, beta 1, beta 2, or from the previous chapter, muscarinic type of drugs. So let's leave the alpha 2 where they are, at the bottom of your page, and let's talk more about them in our cardiac section. Rather, let's work on beta receptors and what they would do to the zigzag line. Now, here as you look at this zigzag, it might make you think that you might be somewhere in Los Angeles and an earthquake is going on. And they wouldn't look that different actually, would it? Let's look at the beta agonist. Here's my baseline. And let's imagine that right here, I'm going to give a beta agonist. Well, you should ask me, which beta receptors? I'm going to tell you, I want a beta 1 effect, and I want a beta 2 effect. Now, what would the beta 1 effect be? It's in the heart. And a beta 1 effect should increase the heart rate. So you know the tracing is going to have to get tighter. A beta 2 effect, that should vasodilate and decrease TPR. As such, it should decrease the blood pressure. Well, let's try and do just that then. I'm increasing the heart rate and I'm dropping the blood pressure at the same time. And you see my pen is now going much faster, is making much greater amplitudes, and is obviously at a lower level than I started with. Look, this is my mean blood pressure before the drug. This is my mean blood pressure after the drug. Also, what I notice is with the increased contractility, I see a nice increase in the amplitude of my pulse pressure, because here I would increase systolic blood pressure, whereas with the decreased TPR, I would decrease diastolic blood pressure. So I have an increase in pulse pressure on the tracing. This tracing would represent the classic beta 1, beta 2 agonist. So as I'm looking at this, the slide is showing you indeed that beta 1 stimulation would increase heart rate, increase cardiac output, increase pulse pressure, particularly from increasing systolic blood pressure. And with beta 2, I'm going to see a vasodilation with a drop in blood pressure, particularly decreased diastolic blood pressure. Hey, who should win? The effect on the heart or the effect on the TPR? Let's see. If I write blood pressure is cardiac output times TPR, who's the main determinant? Absolutely, TPR is the primary determinant of blood pressure. As such, because there is a beta 2 effect, my mean blood pressure will decrease on that tracing. Not too obvious, but you know what we mean by this, and you can follow on your syllabus here. What is very well shown here is the change in actual heart rate. You see that as far as the heart rate goes, it is now very much increased. You also see that there is an increased pulse pressure because of the discrepancy of raising systolic on one hand, decreasing diastolic on the other hand. That's what non-selective beta agonists would be expected to do. Who are your non-selective beta agonists? Well, there's one drug that's called iso for same proterenol. And isoproterenol works equally on beta 1 and beta 2. What could it be used for? It could be used to treat bronchospasm. So here are uses, and one big use is an asthmatic through what receptor? To treat bronchospasm, I'm going to take advantage of the beta 2 effect of the drug. Contrast, another big use is actually to use it in people with heart block, in people with bradycardias, in which case what I'm using here are the beta 1 agonist activity of isoproterenol. But it does tell me that then if I use it as a beta 2 agonist, then the side effect will be that of tachycardia with angina and arrhythmia. Conversely, if I was to use it as a drug for heart block or arrhythmia, my main side effect will be the flushing from beta 2. Wouldn't it make sense then to have people make us some drugs that are more selective? You bet. And to have more selectivity, look what we have. We actually have the drug dobutamine, which really, as far as we're concerned, is the equivalent of a selective beta 1 agonist. It does mean beta 1 more than beta 2, but it means the beta 1 effect predominates so much. It is a drug used for the acute management of CHF. It will increase the cardiac output. Conversely, if I wanted the beta 2 effect to treat an asthmatic, I will have it in selective beta 2 agonist. Several drugs there: salmeterol, albuterol, terbutaline, ritodrin. The first three are used in asthma. The last one is used to prevent premature labor. We will do a section on asthma later on in the syllabus. So as such, you will review all of these drugs there also. Know though that salmeterol is very slow acting, so it's used for prophylaxis only, whereas albuterol and terbutaline, there are even IV forms in order to have an immediate effect in severe situation with asthma. Working on beta 2 means you're working just like epinephrine, so expect to also have vasodilation, which could then cause palpitations from reflex tachycardias, a common complaint of anti-asthma drug. Otherwise, mimicking flight, fright, and fight means these are people who will get more anxious, more restless when they take their asthma medication. And finally, you know that beta 2 stimulation has big biochemical changes, particularly increasing sugars and mobilizing fat. The increased glycogenolysis in muscles of patients with asthma will tend to actually potentially result in tremors. So here you have it, a small review already of anti-asthma drugs. To finish our drugs, which are agonists on alpha or beta receptors, no better things but looking at norepi and epinephrine. The whole idea of norepinephrine and epinephrine is to contrast them. They're called mixed agonists because they have not only alpha but also beta agonist activity. And if we start with the chemical norepinephrine, recall that norepinephrine works on everything except beta 2 receptors, whereas epinephrine will work on all receptors, including the beta 2 receptor. So out of the receptors here, alpha 1 and beta 1 are really critical to understand to see the acute effect of the drug. Let's not forget that alpha 2 is relevant for the negative feedback, but irrelevant for the actual tracings of blood pressure and heart rate. What would I expect then from norepinephrine? Well, let's see. With alpha 1 effect, I should vasoconstrict. Vasoconstriction should increase total peripheral resistance, increase blood pressure. So if I show mean blood pressure prior to norepinephrine administration, I'm expecting an increased mean blood pressure because of the alpha 1 agonist effect. You see this well on the diagram. How about the beta 1 activity? If I look at the beta 1 activity in the table, I'm expecting tachycardia. I'm expecting the resulting increased stroke volume, cardiac output from inotropic changes, and with an increased systolic blood pressure, I should see an increase in pulse pressure altogether because of that increased contractility. So can I see this well here? Well, look, you see the heart rate before norepinephrine, and then you see it after norepinephrine. You see well the increased heart rate from beta 1 activity. And you further see that the pulse pressure has increased primarily because of increased systolic blood pressure from the increased contractility. There is a change in systolic blood pressure because of the beta 1 receptors being in the heart muscle itself. Now, what else can I see on this diagram? Every time a drug increases the heart rate, there's always the potential for a reflex bradycardia. And we show you on the same diagram, but from this point on, I'm squaring it off in yellow here, the effect of norepinephrine if we had a reflex bradycardia at the same time as we had the hypertension, because it's a potential. Don't always expect to see norepinephrine being board tested as having increased blood pressure and reflex bradycardia. It could be just as well tested as increasing blood pressure and heart rate. Who's to say how much blood pressure has changed and how quick it happened? So we'll just need to be able to identify that reflex. Remember that if it's due to parasympathetic, how could I actually block that parasympathetic response? Well, of course, with ganglionic blockers such as hexamethonium, mecamylamine, or with a muscarinic antagonist. And if I was administering a muscarinic antagonist or a hexamethonium-like drug, then I would no longer see reflex bradycardia. What I would see is the tachycardia that is truly the effect of norepinephrine on beta-1 receptors. Let's not forget there's no effect on beta-2. So let me write it in plain English for you right here so you understand what it means, no effect on beta-2. What it means is this. Norepi, and I'm going to write it big, okay, can never lower blood pressure. Period. So I think it's plain and clear. You will never see norepinephrine dropping blood pressure. It cannot vasodilate. Can I say the same thing of the drug epinephrine? Of course not. Because epinephrine has a beta-2 effect, I can imagine a situation where epi would lower the blood pressure. Norepinephrine cannot do that. It has no beta-2 activity. So with this in mind, let's look at epinephrine. And let's remember that because epinephrine has actually all the receptors involved, and beta receptors are more sensitive than alpha to stimulation, I have to imagine epinephrine in 3 different scenarios. Low dose is going to be the first scenario we work with. At low dose, betas are more sensitive than alpha, therefore I see primarily a beta-1, beta-2 agonist activity. You know, it means at low dose, it looks like the drug isoproterenol. What I can see very well is the decreased mean blood pressure from the beta-2 activity and the increased heart rate from the beta-1 activity. If it looks like isoproterenol, what would you do if your board question gives you both answers associated with the tracing or with decreased blood pressure and increased heart rate? Well, your best bet is always to choose isoproterenol as the correct answer. There is no assumption as to the dose of isoproterenol to get this pharmacology. Isoproterenol is always purely a beta-1, beta-2 agonist. For epinephrine, the only way you can choose epi is if you assume a low dose, so it would not be considered a better answer than the drug isoproterenol. Let's try and increase the dose. And as I'm increasing the dose, let's simply go to medium doses. When I'm going to a medium dose, what's happening? Alpha-1 is starting to poke their nose in the pharmacology. And at medium doses, let's imagine something pretty extreme, which is whereas an alpha-1 vasoconstricts, the beta-2 effect is vasodilating. And if that's the case, we would have here some actual physiological antagonism. The vasodilation and vasoconstriction could actually cancel each other. And if they antagonize each other, what should happen then to mean blood pressure? Well, you see that mean blood pressure would no longer change. No change in mean blood pressure, what is left? The only thing left is the beta-1 activity of the drug causing increased contractility and, of course, tachycardia. So is it fair to say that epinephrine at medium dose looks like a beta-1 agonist? You bet. And guess what would be the drug that would look exactly as medium dose epinephrine? The drug dobutamine. Dobutamine was a selective beta-1 agonist more than beta-2. Well, just like for isoproterenol, if the day of your exam you have a choice between epinephrine and dobutamine for a drug that causes tachycardia, by all means, if you have that choice, choose dobutamine. It's a better answer. There's no issue with doses for it. If, on the other hand, dobutamine is not there, epinephrine can be the answer. You would just have to assume, I guess, they gave a medium dose to this patient. So you know what's to finish this diagram then. What I'm going to do last is literally jack up the dose of epinephrine until it is a high dose epinephrine. And with high dose epinephrine, the alpha-1 receptor will predominate. Even though the beta-2 effect is there trying to vasodilate, because of alpha-1 predominance, I will see enough vasoconstriction to raise blood pressure. Although I have beta-1 to cause tachycardia, because of the hypertension, I may see a potential reflex bradycardia. And look at the tracing now. You would increase the blood pressure, you would see the tachycardia, or potentially the reflex bradycardia. Who does this look like? This time, this looks exactly like norepinephrine that we just covered. And you know what? This time I will not ask you to assume if you see this, answer norepinephrine, it's a better answer. No way. You cannot distinguish norepi and epi based on cardiovascular parameter when epinephrine is given at high dose. We're going to have to try and tease that information out of our board question. Look first what could happen. As I'm looking at the dose-dependent effect of epinephrine, at high dose the alpha-1 predominated. Well, fine. What if in my board question they said the drug bronchodilates? You know, if the drug bronchodilates, it must be epinephrine because it's a beta-2 effect that is specific of the bronchioles and that causes smooth muscle relaxation. What if I'm told somewhere in my stem or in my problem that this is a drug that increases glycogenolysis or gluconeogenesis or lipolysis? Well, then of course these are all beta-2 specific effects. Then it guarantees that the board question is dealing with epinephrine. But the biggest issue is, what if they don't tell me that? Then I need to find somewhere in the problem the proof, the evidence that there is a beta-2 pharmacology that is being covered. And to do this is going to be using the story of epinephrine reversal. Let me explain this to you on a separate page first, then we'll look at the text. I'm going to make it hopefully as simple as possible for you. Here is norepi. Its receptors, alpha-1, beta-1. Notice I'm dropping the alpha-2 because I know it doesn't have an acute effect. Here's epinephrine. Epinephrine has alpha-1, beta-1, and beta-2. And that's the only difference. At high doses, alpha-1, beta-1 effect were the predominant effects. So norepi and epi look the same. Who really messed everything up was the alpha-1 that became predominant. So here's the idea. Let's give an alpha blocker. If I give an alpha-1 blocker in blue, I'm cancelling the alpha-1 response to both norepi and epinephrine. Who's left for norepi? The only thing left for norepinephrine is the beta-1 effect. All I can see is tachycardia. And I see no increased blood pressure. But notice, I'm not going to say I'm causing hypotension because there's no vasodilation. Contrast for epinephrine, who's left? Still beta-1, so I'll still see an increased heart rate. But you see who else is left now? The beta-2 receptor. And beta-2 receptor is vasodilating. Now you're going to see a drop in blood pressure. It means literally your patient will go from a hypertension from the high dose epi to a hypotension in presence of an alpha blocker. Essentially, blocking the alpha-1 receptor unmasked the beta-2 effect of epinephrine. You know, this is a maneuver we're going to do readily in the hospital. Imagine you had this patient coming in a state of shock, maybe from secondary to an MI or maybe a bee sting or a neurogenic shock, whichever type of shock you want, big hemorrhaging. That patient is now in stage 2 of shock, hopefully not stage 3 yet, and you're using drugs to maintain cardiovascular function such as epinephrine. As you titrate your patient with epinephrine, you're monitoring on the actual screens what is happening to that patient's heart rate, what is happening to that patient's blood pressure, and you suddenly see that the blood pressure is starting to increase too much and the heart rate is dropping. A sign that you came to high epinephrine concentration in the body that are high enough to cause significant vasoconstriction and reflex bradycardia. You know that this is not going to be good for the shock situation. With the severe vasoconstriction, too much ischemia, you're going to cause more rapid progression to a stage 3 shock, where there would be irreversible damage to tissues such as the kidneys, the brains. Certainly with the bradycardia from the reflex, you're actually compromising further the cardiac pumping function in that heart who's in shock. So what should you do? Besides not giving as much epi, how about giving an alpha blocker? Giving an alpha blocker, which is also in your crash cart, will immediately reverse the hypertension from epinephrine to a hypotension with a vasodilation coming from beta 2. So epinephrine reversal is not only a step one story that we love to see with problems, but it's also an important maneuver that we can do in case of having given too much epinephrine. So let's look at this in the text here. Epinephrine reversal is the use of an alpha-1 antagonist to reverse the hypertension to a hypotension. It is used in a patient who receives too much epinephrine. What was the reason for the hypertension? Well, remember, the hypertension was due to the predominance of alpha-1 receptors on the vasculature, and therefore to the vasoconstrictive effect of alpha-1 stimulation. Contrast, the hypotension comes from unmasking the beta-2 receptors. You cannot see a reversal of blood pressure with norepi, because norepi can never drop blood pressure. It has no beta-2 activity. Well, if you've understood this in Word here, expect to find it in some of the ANS problems we'll give you to practice in preparation of your boards afterwards. What are uses of norepi and epinephrine? Well, obviously, both can be used for cardiac arrest. And when they're used for cardiac arrest, I'm using the beta-1 activity primarily to prime the heart and the pumping of that muscle. In adjunct to local anesthetic, the whole idea is to cause significant vasoconstriction, as we'll see in the CNS section on anesthesia, to prevent the absorption of the local anesthetic, so as to maintain it only in the area where injected it. Well, this is vasoconstriction, and it's the alpha-1 effect of both medication we're looking at here. They can both be used in hypotension, in which case we're using the alpha-1 and the beta-1 activity. But what you highlight very well is that if you were dealing with anaphylaxis, only epinephrine would be relevant. Let's remember that the increased histamine from the degranulation of mast cells, well, not only it dropped blood pressure, but it also caused bronchospasm. And if it caused significant bronchospasm, I need a beta-2 stimulation to bronchodilate. Only epinephrine has this beta-2. Norepinephrine would never be used in anaphylaxis. By the same token, then, same idea. If I had asthma, and particularly a status asthmaticus type of situation, well, epinephrine only would be relevant here for the beta-2 activity. As a matter of fact, in asthma, we have also many other drugs that could be used in the emergency room. But it's just, again, to make sure that you don't confuse when I need a beta-2 and when I really don't necessarily need it.